This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Thank you so much for joining us today for Journal Club by one of our esteemed third-year fellows nearing graduation, just a couple weeks away. Khawaja came to us from Texas. He's a Texas native and is a third-year fellow currently and will be going back to Texas for his first attending job. And today he is going to be presenting a Journal Club about percutaneous management of AR.
Thank you so much, Dr. Coley. Good morning, everybody. Thanks for joining in. So we'll get started. As always, I have no disclosures for this talk. So what I'd like to talk about today is kind of go through a case that's going to highlight some of the challenges of diagnosing as well as managing severe aortic regurgitation in the setting of durable LVAD implantation. We'll talk about the pathophysiology of why this occurs, what are the clinical impacts when this does happen in these LVAD patients, and then we'll kind of use that to segue over to the Align AR trial, which this trial's results were actually published in 2024, and they recently had updated results from their 2-year outcomes presented at the recent TCT conference. So we'll talk about that and actually talk about how in our clinical case it's relevant, and then we'll kind of talk about future directions for percutaneous management of aortic regurgitation. So our patient is a 26-year-old male, no past medical history whatsoever, came into an outside hospital with sudden onset acute substernal chest pain. Collateral history from his family was notable that he'd been having some URI type symptoms maybe a week or two prior to his presentation. Of note, his chest pain, had been going on for over 24 hours prior to him actually going to the ER. He didn't seek help till it was a little later in his symptomatology course. And unfortunately, the first hospital he presented to was not PCI capable. He had EKG findings and troponin that were concerning for a STEMI. He was treated medically with tenecteplase, aspirin, and then transferred to a PCI capable hospital several hours later, and then taken emergently to the cath lab. We don't have those films, but reportedly had acute occlusion of his distal left main and prox LAD, underwent successful POBA and aspiration thrombectomy without stenting. And then at the time, he was also noted to be in profound cardiogenic shock, required CP Impella placement, had a PA catheter placed, and essentially was transferred over to our hospital for management of cardiogenic shock. He comes in on multiple inotropes. He'd been having some ventricular tachycardia as well, been started on amio, and been intubated and sedated. He notably is on P6 support on his CP Impella when he arrives. And so the first thing that we have here is his echo. So as you can see, severe LV dysfunction. You can see the Impella, it looks a little bit shallow there, but otherwise notable for severe, obviously cardiogenic shock type picture. Got some mild to moderate RV dysfunction as well. Here's another kind of apical 4-chamber view here on P6 support. Notably, I will say that it looks like there is some regional wall motion abnormalities in terms of the apex and lateral wall look more akinetic as compared to the basal septum. But overall, this EF was called around 15%. Given his young age and for him to have a left main STEMI and prox LAD STEMI is very unusual. So you wonder about the possibility of a cardioembolic MI. So they did a contrast study, but there was no LV thrombus noted. The outside hospital reports did not note that he had an LV thrombus either, so it's a little bit peculiar. And then the other notable thing I want to point out on this apical 5-chamber view here is that there is some degree of aortic regurgitation here. Obviously, it can be a little bit difficult to assess, and we'll talk about why that is when you have mechanical circulatory support in place. But obviously, when you have a percutaneous device across the valve, you can expect to see this to some degree. So this was called mild to moderate aortic regurgitation at the time when he arrived at Emory. So he underwent a full heart failure workup, was managed in the CCU. He unfortunately was diagnosed with HIV as well. Incidentally, he had a CD4 count that was in the 400s, but very high viral loads. He remained in profound cardiogenic shock, was actually upgraded to a 5.5 axillary Impella. However, over the next several days, was unable to be weaned from his support, and then he underwent advanced therapies evaluation. Now, began with a left heart catheterization and actually noted, patent flow. It is notable for very sluggish flow, TB2 flow, in the left system as well as the right system. So, but there is no evidence of any occlusion or stenoses. The clinical picture here obviously is still a little bit unclear. The etiology of his heart failure, why did he have this STEMI? Is this a viral cardiomyopathy, idiopathic? Is this, myocarditis? It sounds like he probably had a cardioembolic MI, but there was never any, LV thrombus identified. Hematology was unfortunately not consulted during this admission and a subsequent later admission, but anyway, regardless of that, given his young age, he would have ideally been a great candidate for a heart transplant, given how sick he was at the time. However, with the HIV being uncontrolled, he was also found to have high panel reactive antibodies. He had active substance use as well with THC and tobacco. The heart transplant team felt he may be a better candidate for a durable LVAD with a HeartMate 3, so he underwent successful implantation with CT surgery. Was started on ART as well. Had very good response to that, was actually discharged 2 weeks after his HeartMate was implanted. And just for the purpose of time, his post HeartMate 3 implantation echo did not show any evidence of, aortic regurgitation. So we kind of checked back in with him 4 months later after his HeartMate was implanted. He's seen in clinic and he's having low output symptoms, very lethargic, decreased appetite, terrible shortness of breath. So he was scheduled for an outpatient right heart cath, which was notable for not terrible wedge pressures, a wedge pressure of 15, but a CVP pressure notably is 11. So the CVP to wedge ratio is kind of concerning for possible RV dysfunction, even though his PA pulse pressures actually look to be okay. His RV seems to be generating a decent enough pulse pressure. But his cardiac index was also found to be 1.6, so he was concerned for cardiogenic shock, low output state, and this was thought to be due to primarily RV failure. He was started on inotropes, epoprostenol. Unfortunately, had an aspiration event, got intubated again, and then he had a repeat echo done at this time. So this is with the HeartMate 3. This is his initial echo on this admission. So it's notable for, you can see there's a good degree, moderate to severe mitral regurgitation, and there is that aortic regurgitation there. Difficult to say in terms of quantifying and qualitatively assessing its severity, but looks to be at least mild to moderate. So he was admitted to the ICU, underwent aggressive diuresis, had multiple parameter changes with his LVAD speed settings. Thankfully got extubated, but still requiring a lot of inotropic support, remained in cardiogenic shock. And this was thought to be due to be his primarily RV failure. So they got CT surgery involved and said, okay, let's take him and put in potentially an RVAD support protect duo device. But the CT surgeon astutely noted that, the high P pressures, the pulse pressures did not really fit the picture, and he didn't think that it was all the RV. So they said, why don't we take a better look at the aortic regurgitation to see what's really going on? So they got a repeat echo, and here you can tell the aortic regurgitation maybe looks a little bit worse, maybe moderate to severe. There's a good degree of mitral regurgitation. M mode is also kind of helpful in some of these patients. It's not necessarily, you're not necessarily seeing premature closure of the anterior mitral leaflet, but you are seeing kind of abnormal closure where you can see over here it doesn't have that normal appearance. So this could sometimes suggest severe mitral aortic regurgitation, because that jet can be kind of affecting the closure of the opening of the anterior mitral leaflet. So given these findings, they said, okay, why don't we send them for a cardiac CT? Let's take a better look structurally at the aortic valve. So for the purposes of time, this is just a cross-sectional cine of the aortic valve on CT. And what's notable here is that obviously the aortic valve is tricuspid. There's no calcification. This is a young gentleman. The aortic valve is not opening in the cardiac cycle, but there is a central non-coaptation defect that's pretty sizable there, which is likely contributing to the aortic regurgitation. In this setting, the patient had been undergoing several LVAD parameter changes, but you obviously can be limited by this because as you increase LVAD parameters, in terms of speed. As you go up on the speed, you can, worsen aortic regurgitation while improving mitral regurgitation. If you go down on the speed, you can worsen the mitral regurgitation and improve aortic regurgitation because of the flow hemodynamics. And so there's also the fact that both of these changes can also affect the degree of tricuspid regurgitation. This patient had multiple valves implicated and had already been trying to, adjust the speeds without much success. So during this time, given how sick he was, his actually had good improvement of his viral load and CD4 counts on ART for the past several months. He was actually listed status 1 for transplant. There was the concern about him, the chances of him actually making it to get a compatible heart because of his blood type. He was actually O positive. So given his aortic regurgitation, given how sick he was, surgery was reconsulted to say, hey, is there anything that you guys can do surgically for this valve? But this patient already had a sternotomy. The possibility of him potentially getting having another sternotomy in the future, if he were to get a heart and if they were to operate now, would be 3 sternotomies, which obviously is concerning for any patient. So in this setting, they reached out to the structural cardiology team to consider percutaneous interventions for the aortic regurgitation. So before we get to that, we can just do a little quick background on acute aortic regurgitation. In our non-LVAD patients, the causes commonly is infective endocarditis. You think about aortic dissections in terms of etiologies. Other things is iatrogenic complications from transcatheter procedures, blunt chest trauma. The big thing to note is when you have acute severe AI, you're going to have sudden volume overload on the left ventricle, severe pulmonary congestion, low cardiac state. These patients are going to be very, very, very sick. So it requires urgent diagnosis intervention because it's a hemodynamic emergency. So I was kind of curious in terms of what does the literature and data say about aortic regurgitation after mechanical circulatory support, because obviously our patient had multiple percutaneous and surgical devices implanted across the aortic valve, as you can imagine. So an Impella CP, a 5.5, an LVAD. So, in terms of Impellas, as it commonly makes sense, is the device is placed across the aortic valve, causes leaflet malcoaptation and subsequent regurgitation that can even lead to trauma. The data is limited in this area in terms of how prevalent this is, but in terms of 5.0, Impella 5.0 support, there's almost some studies suggest that almost 90% of patients develop some degree of aortic regurgitation, with about a third of those being at least moderate in severity. So then I kind of wanted to ask the question, what about aortic regurgitation after HeartMate 3 implantation, specifically with our patient? And the data does show that the incidence of aortic regurgitation after HeartMate 3s is lower as compared to prior generation LVAD devices, durable LVADs, but it's still a relevant kind of clinical concern. We don't have a ton of data, but there is an estimation that moderate or severe aortic regurgitation occurs in about almost 8% of patients by 1 year, and it continues to progress over time. And then this is also associated with increased frequency of right heart failure, which, as we know, has poor prognoses and increased mortality. The other thing to note with this is that we probably don't have a lot of data on this because of how difficult it is to assess aortic regurgitation in the aortic valve in this patient population. But this is a nice little illustration here, just kind of illustrating that the interaction between aortic insufficiency and other hemodynamic events during LVAD support has a lot of hemodynamic consequences on cardiac function, LV preload, systemic perfusion. So, they're kind of intertwined. Aortic insufficiency can contribute to right heart failure, and both of those together can progress down this cycle, leading to arrhythmias, readmissions, cardiac, renal cardiorenal syndrome. You can even have GI bleeding related to angiodysplasias from the shearing forces, shearing von Willebrand's factor. So whenever you're going to manage aortic regurgitation, you have to consider the right heart failure as well, and think about, how can the device speed escalation in patients who may have uncoupled right heart or right ventricles may not have significant improvements. So it's important to recognize that relationship, and that's potentially maybe what was going on with our patient to some extent. What's the mechanism of aortic regurgitation after HeartMate 3? So it's multifactorial. There's different kind of theories out there. One of them is aortic valve degeneration because of stasis, blood stasis, and thrombosis. So this is called disuse degeneration. You can have exposure of the aortic valve and the aortic wall to high shear stress and strain. So that's shear degeneration. You can have dilation of the proximal aorta. There's also additional factors that can increase your risk of aortic regurgitation. So smaller grafts of the VAD can have a higher flow and higher flow velocities. The proximity of the aortic cannulation to the aortic valve and the anastomosis angle can increase shear stress. If you have a closed aortic valve persistently, that can also actually lead to higher shear stress and duration of stress. And then interestingly, there's been studies and data that suggests that women and smaller BSA patients have increased shear stress. So there are some patient-related and device-related factors that can contribute. How do you prevent this from happening? So it's very important to prior to implantation of the HeartMate or LVAD is to assess aortic regurgitation. But again, this is very difficult because so many of these patients are so sick, they're already on temporary MCS. The ISHLT guidelines from 2023 suggest they give a class 1 recommendations that more than mild aortic regurgitation at the time of LVAD implantation should be addressed with a aortic valve replacement. That's a class 1. They do give a class 2B recommendation for aortic valve repair. You could do different types of, valvuloplasty, oversewing the valve, but that's a weaker recommendation. So, but overall, the aortic valve needs to be addressed. And then the big thing to note is that it's difficult to assess aortic regurgitation in these LVAD patients. You don't have normal LV contraction, you have low cardiac output. So your normal measurements and parameters that we use with color Doppler, PISA, pressure half time, they're not as reliable. You have altered flow hemodynamics. Your pressure half time is very dependent, as we know, on ventricular compliance and preload. So all these things that we normally use in our average, patients are very unreliable and makes it very difficult to quantify. So there are other things you could consider. A TEE is not a bad test, but obviously it does have its limitations if there's an eccentric jack flow artifacts. Cardiac MRI would be ideal, but again, these patients have an LVAD in place, they have metallic artifact, device incompatibility, things of that nature. CT, which was done in our patient, is useful for looking at the structure, but it doesn't tell you anything about the dynamic flow. While the guidelines do recommend, surgical interventions at the time of HeartMate 3 implantation, I will say that it's interesting that they gave such a strong recommendation when there's actually no randomized data to support this, comparing aortic valve interventions at the time of HeartMate 3 implantation. And there's actually some evidence in terms of retrospective data and subsequent analyses of trials that patients who have HeartMate 3s implanted who undergo aortic valve replacement or repair actually have worse outcomes, worse survival, longer stay, increased right heart failure. So that's just a little caveat that I want to note there. But so the data is a little bit mixed. Anyway, back to our patient. I looked at the op note. There wasn't any mention of aortic valve repair at the time of his HeartMate 3 implantation. But so anyway, it's just important to note that. Regardless, he was critically ill, not deemed a candidate for, reduced sternotomy to address this aortic regurgitation, especially since he was listed for heart transplant in the background. So what are our structural options? There's several TAVR valves that are kind of off-labelly used for aortic regurgitation up to date. The two most commonly implanted are balloon expandable Edward Sapien valves and then Medtronic core valves that have had multiple iterations and different versions of these attempted to manage aortic regurgitation. But again, they weren't designed for aortic regurgitation specifically. They were designed for aortic stenosis. So I was kind of curious, what does the data show for these kind of older valves and older generation valves? It's been studied for several years now. This was a systematic review of 13 TAVR studies for aortic regurgitation, where 80% of patients had self-expandable prostheses, whereas about 20% had balloon expandable. And they had variable device success implantation rates, anywhere from 75 to 95% success. A good bit of patients, about 7-10%, required implantation of a second valve. Rate of all-cause mortality in this population at 30 days was around 7%, so not negligible. But then there's data comparing, self-expanding versus balloon expanding. Is there any difference? This was an international study that kind of looked at TAVR valves for severe AI. This had notable for varying device success rates. There were success rates were a little bit higher with the self-expanding valves, about 84% versus 76% for balloon expanding. And interestingly enough, there were very similar rates of complications in terms of valve embolization, second valve being needed, residual aortic regurgitation, and then you can note pretty high rates of pacemaker implantation in the above 20%. But there was not a significant difference in terms of self-expanding, balloon expanding. But again, these are the older generation TAVR valves. So this was a different study that looked at the older generation versus newer generation and TAVR valves for pure native aortic regurgitation. Had 330 patients that had high STS scores of about 6 to 7%. And essentially, the newer generation devices had significantly higher device success rates, about 80% versus 60%. They had lower rates of second valve implantation, lower rates of post-procedural residual aortic regurgitation. This is probably because the newer generation devices had different designs in terms of their skirt lengths. They were more scalloped, they were more extended. However, there were no significant differences in the 30-day endpoints between the two groups. But the cumulative, rates of all-cause and cardiovascular death at 1 year were actually higher with the older generation valves. So it's important to kind of look at that. The older generation valves they looked at were the CoreValve and the SAPIEN XT, versus the newer generation included a cohort of different valves, and we'll talk about the UniValve in our discussion. And interestingly enough, I actually came across this too. This was actually a meta-analysis looking at percutaneous TAVR valves for aortic insufficiency in patients who actually had LVADs. This is actually a study that had 29 patients. Notably, the TAVR valves that they only used actual TAVR valves in about 25% of the patients. They also used occlusion devices in the majority of patients. They showed that the aortic regurgitation was significantly improved with both sets of devices. So they were both kind of effective. However, the survival rates were a little bit significantly higher with the TAVR valve as compared to the closure devices. But notably, the TAVR valves in this study that were used were Edwards SAPIEN, Medtronic CoreValves, and the Melody valve. So they weren't using the kind of newer valves such as the UniValve in this study. The occlusion device that they used, the occluder, was an Amplatzer septal occluder. So what are the kind of challenges with conventional TAVR devices in aortic regurgitation? In these patients, you don't have, a lot of the times you don't have aortic cusp calcification. And aortic stenosis TAVRs, you need that calcification to kind of secure and seal that valve to prevent embolization. You have sometimes dilated aortic roots. You have, kind of different anatomy. So that can lead to valve embolization, that can lead to paravalvular leaks. And so because of that, there's using these conventional devices, TAVR devices, is a little bit tricky. There's also technical challenges. You don't get good fluoroscopic evaluation of the native valve when you're implanting. And again, there's the insufficient anchoring. So the big thing about this is that in order to kind of combat some of these issues, the way to prevent that is that there was a recommendation to generously kind of oversize the valves to kind of seat them better and prevent embolization and paravalvular leaks. However, that also carries a risk of annular rupture and valve dislocation, as well as pacemaker implantation rates. So big things, high with these off-label TAVRs with older generation valves, high paravalvular regurgitation rates, anywhere from 10 to 24%, depending on the generation of valves. High valve embolization rates, anywhere from 7 to 15% at 30 days. Technical success rates, as I mentioned, were anywhere from 60% to 95%, so kind of variable. And then mortality rates, at least at 30 days, were anywhere from 10 to 20% for some of these older valves. So the valve that we'll talk about is the Unitrilogy valve. It's not currently FDA approved yet, but expected to receive FDA approval later this year. It's available in 3 sizes: 23 millimeter, 25, and 27 millimeter. It's used to treat aortic annular perimeters between 66 and 85 millimeters. There's some sizing recommendations that they give that is supposed to, allow proper valve seating and prevent embolization. It has this unique design. It has this nitinol expanding frame that they actually use to clip onto the aortic cuffs to allow it to seal. It has these open cells that allow coronary access. It's a pericardial porcine tissue valve. And then it has this locator technology, which allows you to kind of locate it under fluoroscopy. And it has this sealing ring to allow for sufficient anchoring. So this is just like the sizing recommendations that the Univalve trilogy kind of gives in terms of annular perimeter to kind of prevent valve embolization and perivalvular leaks. So the big things with the placement is you need to align the valve with the native cusps. There's these locator clips that'll essentially clip onto the native leaflets to form a natural seal. And then you kind of deploy that valve subsequently. So here's a little clip from their website that's just kind of depicting how you actually deploy the valve. So it's actually delivered through an 85 centimeter sheath, which has an outer diameter that's equivalent to about 18 French. So what you do is you essentially line the sheath at the sinotubular junction. You advance the delivery system to the aortic root, and then you want to ensure that the locators are confirmed in all three native cusps. You want to make sure you have appropriate depth, and then you essentially deploy the valve. So they're just kind of showing some of these steps here. You want to ensure that your sealing rings at the annular plane. So they have this device has different markers on it to kind of obviously tell you where you are and kind of gauge. So we'll get to the Align-AR trial. So we'll start with the 1-year data and then dive into the 2-year outcomes. So this was a prospective multi-center trial looking at it was a single-arm, non-randomized study that has plans for 5-year follow-up. The main question they were asking is how safe and effective is it to treat moderate to severe aortic regurgitation using the Univalve device and patients that are high risk for surgical aortic valve replacement. So we'll go through it through a PICO format. In terms of the population, so this included patients with severe regurgitation that were symptomatic, that were high risk for SAVR. And the way they determined that was if patients had an STS prom score that was higher than 8%, or if they had a score that was less than 8%. But the heart team agreed that there were other comorbidities that weren't captured by the STS model. And then obviously patients that had anatomy that was suitable for the Univalve implantation. Interestingly enough here, they excluded a lot of patients that, or a lot of patients with characteristics that our patient actually has. They excluded patients that had bicuspid or unicuspid anatomy, prior prosthetic aortic valves, worse than moderate mitral regurgitation, severe RV dysfunction, or LV dysfunction, aortic disease, or emergent cases. So our patient would definitely not have fit this inclusion. Patients that had cardiogenic shock were also excluded. There were other hosts of other things like severe end-stage renal disease or advanced CKD, patients who had stroke, things like that. Here's just showing some of the population characteristics, but the big highlights is their average age of patients that were included was about 75. Average STS scores were actually about 4%. And then most patients had severe aortic regurgitation, about 64% of them, and then about a third had moderate to severe, and the average EF was about 54% in this patient population. So they essentially implanted the Trilogy Univalve in 177 patients that were included at the 1-year follow-up. And again, there was no comparison group for this trial. It was a single-arm trial. So the primary endpoint was 1-year all-cause mortality that was compared with the non-inferiority performance goal of 25%. And then the primary safety endpoint was a composite of all-cause mortality, stroke, major bleed, major renal injury, vascular complications, new pacemaker implantation, or residual moderate or severe aortic regurgitation at 30 days. And that was compared with a non-inferiority with a pre-specified performance goal of 40%. They had secondary endpoints such as technical success, moderate or greater aortic regurgitation after implantation, KCCQ. They looked at LV remodeling with echo, NYHA class, and 6-minute walk times. So here's some of their safety endpoints at 30 days. Notable here is that there were about 2% of patients died at 30 days. Stroke rate was at 2%. 1% was disabling and 1% was non-disabling stroke. What's notable here is that pacemaker implantation rate was quite high. It was at about 25% at 30 days, which kind of persisted to the 1-year outcome. And at 1 year, although they didn't have like a table or graph for this, was that the all-cause mortality at 1 year was about 6%. And then overall valve embolization rate was 2%. The one thing to note about the pacemaker implantation rate is that in the trial, they actually used a sizing algorithm for the unit valve that was adapted from prior TAVR studies that use different oversizing thresholds. And so as they noted the high rate of pacemaker implantation, they actually downgraded the sizing a little bit, as well as the depth of implantation. So the pacemaker implantation rate in the first third, in the first 2/3 of patients was actually about 29%. And then in the latter 1/3 of patients was actually lower at 14% after they had adjusted these parameters. So that's something to note. Here are some of their secondary outcomes. So there were significant improvements in NYHA class. As you can see, a lot of patients had predominantly class 3 symptoms that were either class 1 or class 2 at 1 year. And then improvements in KCCQ as well as 6-minute walk distance that were all significant. In terms of echo parameters, the big things to note here is there were significant improvements in LV and systolic dimensions, LV mass, and then the one thing to note is that there was mild or mild to moderate paravalvular regurgitation in about 20% of patients at 30 days, but that actually decreased to 8% at 1 year. And this is just kind of showing here that the KCCQ, most patients had significant, or at least moderate or significant improvements in their KCCQ scores. So here's the 2-year outcome data from TCT. So notable here is that the cardiovascular mortality rate was largely unchanged from 1 year to 2 year at 6 to 7%. However, there was a notable jump in all-cause mortality from about 7-8% to 15% at 2 years. The big thing to note there is that in that first year, the mortality was mainly driven by cardiovascular deaths. However, in the second year, from valve implantation, it was mainly non-cardiovascular deaths, as you can see that they're listed out here. So a lot of non-cardiac etiologies there. Stroke rates were about the same. Disabling stroke about 1 to 2% that persisted from 1 year to 2 year, and then about 4% for non-disabling stroke. Stayed pretty similar. The big thing to note here, this is just kind of laying out what we just discussed, is that most of the outcomes stayed the same aside from the all-cause mortality, which again was driven by non-cardiovascular mortality at the 2-year mark. Stroke rates were the same, but the pacemaker rate was about 25% throughout 30 days, 1 year, and 2 years. So that is notable. Paravalvular leak remained low at around 4%. So that was nice to see there. And then LV remodeling was still significantly, those benefits were maintained in terms of LV and systolic diameter and volumes from 1 to 2 years. NYHA class also maybe maintain benefits and symptomatology for these patients, as well as this was also measured by KCCQ. So back to our patient, given the circumstances, given how sick he was deemed a candidate for emergent approval for the unit valve. And so this is his intraprocedural TEE. So as you can see, there were some better pictures that I could have gotten, but here you can see that there is that continuous aortic regurgitation jet there. And then this is actually a clip from the procedure itself when they're implanting. As you can see there, that nitinol frame actually clips onto the aortic cusps and then deploys. So it's a self-deploying valve. And then this is the post-implantation TE during the procedure. So as you can tell, there's no further regurgitation whatsoever. So interestingly enough, right after they implanted the valve, the patient's hemodynamics improved significantly. He was weaned off of all his cardiac support, eventually discharged home, and is actually doing well. He actually just had his follow-up visit, and he seems to be doing well from a symptom standpoint and everything. So obviously this trial and the valve have its limitations. This is by no means an endorsement of this valve for all these cases. But big things to note, obviously it's a single arm, non-blinded, non-randomized study. There's no comparison. There's no comparison to surgical valve replacement. Even though the population was higher surgical risk, they excluded a lot of patients, advanced heart failure, advanced kidney disease, advanced RV failure patients. So we see a lot of that in our advanced heart failure patients. So, take that with a grain of salt. We need longer term data, obviously, which will come from this trial as well as another trial and additional trials that I'll talk about. And then, the sizing and technique of implantation, they made changes in the middle of the trial to kind of mitigate the pacemaker rates. The univalve itself, in clinical practice sounds great, but it seems like there's a kind of small set of patients that you can actually use this in, because a lot of aortic regurgitation is driven by aortic pathology, aortic dilation. So as of right now, it doesn't seem like it's going to be usable in a lot of patients, but that could change in the future. The high pacemaker rate is not negligible. The question is that primarily due to sizing and implantation depth, or is there a learning curve that'll get better? But that is something to pay attention to. The sizing requirements and inability to use it for dilated aortic roots, as I mentioned, and then there's no ability to recapture the valve after you deploy it, so that is another limitation of this device. There's another ongoing trial called the ARTIST trial, which is going to look at severe aortic regurgitation, and it's going to have a heart team that essentially is going to evaluate patients that are suitable for either SAVR or TAVR. And they're actually going to be randomized to either the Trilogy valve or the SAVR. And they're going to look at endpoints at 12 months in terms of death, stroke, urgent rehospitalization. So that'll be interesting to see what that shows. What are some future directions for TAVR and aortic regurgitation? We need randomized data, need to compare it to SAVR. Is there any utility to use it in patients who also have aortic stenosis, calcified aortic leaflets and cusps, because those patients often do have concomitant stenosis and regurgitation. Is there any way to reduce the pacemaker rate further? How do we restratify those patients prior? Is there any utility in sicker patient populations? As shown with our case, it seemed to work great. And then, given that these are tissue valves, obviously they have a limited lifespan. So what do we do about if a patient requires, future reintervention to this valve? What does that kind of look like? So I want to give a special thanks to Dr. Diamond and Dr. Khawaja for kind of helping out with this case and giving me advice on the presentation and feedback. And I'll open up for questions.
Thanks, Muz, for that really thorough presentation. I wondered for you, looking back at your case, what's like the one biggest point that you learned on your case?
I think that some of the big takeaways are make sure that as both the cardiology team, as the heart failure, the CCU team, and the surgical team, that you are looking at the aortic valve at the time of LVAD implantation to make sure that somebody has thought about it, whether it needs to be intervened on or not. Have we assessed for aortic regurgitation? Understanding that, severe aortic regurgitation can have very severe clinical impact in these patients in terms of RV failure. I think with our patient, you were seeing a combination of both of those issues that were kind of exacerbating each other. And then understanding the role but limitations of percutaneous interventions for aortic regurgitation. There is a role in the future potentially, but we need to take that with a grain of salt. I still think that surgery should be probably the go-to for a lot of these patients, but that could change in the future. And making sure that you use a multidisciplinary approach with all of these patients, as they did in this case. They did an excellent job of kind of working together to get a good outcome for this patient.
Stan Sherman, can you discuss anticoagulation, the anticoagulation acutely and ongoing with this valve and this particular case?
So I think with this patient, obviously, because they had the LVAD, they were just continued on their Coumadin. In terms of the trial and in the valve, I'm not totally sure what exactly what specific antiplatelet therapy or anticoagulation recommendations they have. Obviously, it's off-label use currently still. It's not been FDA approved just yet. So I think there needs to be kind of investigation into that. So it's a good question. But for this patient, there wasn't any additional, antiplatelet therapy added for him. He was just continued on his Coumadin therapy, given his higher INR goal with the LVAD in place.
Thanks,
Yeah.
Moose. That
Well,
was,
I was
oh,
sorry. One quick thing I was gonna mention. Moose, you mentioned that a lot of the traditional ways that we assess with echo AI in patients with VAD just don't work very well for all sorts of reasons. Not the least of which is that it's continuous. There are, I guess it's at least worth mentioning, and you may have said it and I just missed it, but there are a couple of other parameters that have pretty good data in terms of assessing severity, one of which is the ratio of the velocity and the outflow graft in systole and diastole. There's also the kind of slope or acceleration. We've been trying in the echo lab to pay more attention to these things. The interesting thing is that these are also parameters that are sort of hard to get and hard to look at reliably. I have found the slope is very difficult, but the S to D ratio in the outflow graft can be helpful and has pretty good correlation with hemodynamic data in the cath lab. So it is these are sets of parameters that have been sort of recommended for looking at AI in bad patients, and I think when we can, it's good to pay attention to it. My takeaway is that it's a really under recognized problem in terms of frequency. So the more we can get familiar with those things, and hopefully maybe get some more consistently usable ways to assess this, I think it'll be helpful. But that's one set of parameters you can use to try to look at this.
Yeah, that's a good point. Thank you.
yep. Piggybacking on that, Neil, in this patient, no one had really thought about AI. And if you look back at his echoes, at least I think the initial one when he was in the hospital, it was read as mild in that first picture you showed, which, someone who looks at these a lot, that's more than mild. Like once you're seeing multiple colors in the jet, like it at least should raise your suspicion. I just hadn't initially looked at it myself, but when you read the report, it says mild. So you really have to have a high index of suspicion, especially for like a fresher VAD who you didn't know had AI before. I mean, I've seen these come up in older VADs who have had it for a while, but and I mean, anyone can have some, but it was just, not clear. And honestly, we thought he had RV dysfunction because of that cath lab study that he had. As they ramped up the VAD, his CVPs went up. So it just seemed obvious that that was the issue. But you can really have both, kind of as you mentioned, when you have AI, you often have RV dysfunction as well. And you have to really just like kind of think about both. And then the other thing that was a learning point for me is usually I say things like swans don't save lives because I think that often they don't. They're nice to have, they're not necessary. In this case, this patient didn't have a swan until he went to the OR. And that's when we discovered his PA pressures were so high. And even though we'd been pushing for one before, he came from CBICU, we didn't have one. So in his case, a swan would have been really, really helpful and may have prevented some of this dire situation. He really, I mean, I thought he was going to die before he got this valve placed because he just looked so bad and was on multiple high dose inotrope suppressors and just really decompensated. I mean, it was scary. And the last thing I'll say is, I don't know if Nick is on, but it'd be interesting to hear more about like what his experience with these valves have been. I mean, I think you picked an awesome trial to talk about because this is really cutting edge. And, as far as I know, only a handful of these have been put in VADs. The plan is to do a trial to put these in VADs. But, for our VAD patients, often the options are either transplant or nothing. And I have made someone a status 1 before for significant AI with a VAD and they got transplanted, but not everyone gets there and not everyone can, is a candidate at that point. So these patients get really sick very quickly. And this is just an awesome opportunity to like give them something else that we can offer them that will extend the life of their VAD.
Yeah, thank you.
Hey, Muz. really good talk and very comprehensive, and thanks for doing it. Answer Jamie's question, our experience is still limited here at Emory, but structural team is very excited about upcoming approval. I think we're talking about 6 months probably. It'll be approved for high risk or inoperable patients. We enrolled about, I think, 8 to 10 patients into the Align AR trial from Emory, and we've done probably another 10 or 15 as continuous access protocol and as emergency and compassionate cases. It definitely worked for this patient. The technically valve is very easy to implant. There aren't many steps, as you showed, and it's very simple if your anatomy works well. The pacemaker rate is probably from oversizing, and you mentioned that they got it down to 14-15%, which is still higher than our traditional pacemaker rate of 8%, but I think it's getting in the right direction. The one thing that you mentioned is very important. It's a small subset of patients, right? So a lot more people have aortic stenosis than aortic regurgitation, but even within the small subset of patients, a lot of them, not being able to treat it by surgery, which is class 1 indication because of their comorbidities. And I think a lot of them just stay undertreated and then, eventually progress to heart failure and die. So, like I said, we're excited about this valve coming on in US, and there's also another valve called J valve that was bought by Edwards Company from originally designed in China. That trial will enter a pivotal trial in US very soon, and it'll be a second competitor valve for the aortic regurgitation. So I think Jamie mentioned that. I think Genovalve is, or Genovalve is the correct way of saying it. They're trying to start an LVAD arm for their trial, which will be interesting because we'll be able to help maybe some other patients with a similar problem like the patient you described.
Muzamil, this is Mahmoud. A very good talk. Thank you, and a beautiful review as well. And then I will have a small little side chat with my partner and colleague, Dr. Jamie Dimon, about swans not saving lives. So please, we can erase that from our transcript from today, please. This, of course, was a joke. This was a very interesting case, and like everybody's mentioned, you highlighted it very well. And something that I am personally looking into is trying to see the long-term outcomes out of aortic regurgitation repair or management in LVAD patients. Maybe something to compare our, traditionally amplats or closure devices or apparatuses versus total valve replacement like this one and others. And this will be an interesting thing to look at. That, of course, something like this is going to be very, very hard to do because the population is very low. However, I love that how you highlighted your points, and I want to just reiterate them, is that aortic regurgitation is sometimes overlooked at time of VAD surgery for multiple reasons, not necessarily from omission, but these patients are sick, they have impella, sometimes they have something else going on, and then aortic regurgitation is one of those complications after LVAD surgery that doesn't get better. It only gets worse, and therefore addressing this head on is going to be very, very important. And I'm proud to be part of this absolutely fantastic structural team. We come together, this multidisciplinary talks about these things, and we come up with consensus. And when we try to help these guys, so thank you very much. Fantastic talk, and and see you later.
Thank you.
And Muzamil, there is an article I may send you that I think some of the points that Neil was talking about of quantification of AI in LVAD patients. like other methods to do it, I may send you that paper for your reference. It's a very
Yeah,
nicely
absolutely.
written paper that's easy to follow.
Awesome. Thank you.
Well, if there are no other questions or comments, I'll ask Muz if he has anything he wants to wrap up with, and then we can call it a day.
No, I think we're good.
Muzamil, did you mention what happened to the patient, or I can give a quick update on this gentleman?
Yes. I mean, I haven't looked into the outpatient notes, but I talked about how he was discharged. He was just seen in clinic, I think, recently.
That
Um,
that is correct. He was someone who was status 1. All of us worried about that. We were taking it hour by hour. Ended up leaving the hospital on his feet, off inotropes, with his LVAD, doing very well. So thanks for everybody taking care of him.
yeah, thank you guys.
Thanks, everyone. See you next week.
The preceding program is copyrighted by Emory University.